Evening, everyone. Just giving a moment for everybody to get logged in here. Thank you so much for joining us today. All right, I think we're in good shape here. So Leslie, if you could have us stream live on YouTube as well, that would be great. And let me know when we're started there. Great. Okay, so thanks again to everyone for joining us today. You're here for our first of our three 2026 annual public information sessions. My name is Erica Schiavelli. I'm the Deputy Executive Director here at the GIC. And we're looking forward to diving into this with you all today. Next slide, please. Great. So we have our agenda here. Wanted to let you know that sorry, I'm having a little bit of voice issues this morning from a cold, so my apologies. These sessions are part of our annual process to develop and finalize the design and premium rates for health insurance plans for the upcoming annual enrollment coming in April. So as we've done for the last 5 years, we're holding the sessions virtually by Zoom, and we're live streaming them. And we'll also be posting the video of this session to the GIC's YouTube page and our website. I'm going to be joined today by Matthew Vino, who's our executive director here at the GIC, as well as senior staff from GIC who will be presenting on their various subject matter expertise, as well as helping out for the Q&A portion of the session. So just a couple of housekeeping items. Your participation in this public information session is certainly not required for you to participate in annual enrollment. It's completely voluntary and informational only. And we do have closed captioning that is embedded in the live stream, as well as by a link in the Zoom chat. And we also have ASL interpreters who are available, and you should be able to see them on screen now. Okay, so moving on again to our agenda. So we'll start with a brief overview of the Group Insurance Commission and our carriers. You are all probably very familiar with this, so we won't spend a ton of time on our existing carriers. We'll walk through what you can expect for the upcoming plan year, and then we'll get to questions and comments. So we know that there has been a lot of conversation about some of the potential plan design changes that our commission has discussed. So we're going to spend a lot of time on that today and really set the stage and help folks understand what it is we're looking at and what our plans, what the timeline looks like going forward. I see many of you have already found the Q&A button. So let me just go ahead and talk us through the Q&A and what you'll need to know for that. So please submit any of your questions at any time during our webinar using the question and answer function in Zoom. Please do not use the chat. The chat will not be taking questions from the chat. If you are watching through the YouTube live stream, you won't be able to use the Q&A function, but we still have other methods for you to get us your questions. And so you still have the availability to do that. So please, if you're watching through YouTube, please go ahead and submit questions to us via gic.info@mass.gov, and we'll be happy to take a look, and I'll be monitoring that inbox through this meeting as well. Just a few notes about our question and answers. Questions that you ask will be private until they are answered, at which time they'll become visible to all attendees. The question and answer function is not for feedback or for commentary. So if you have feedback, comments that you'd like to provide to the GIC, we are happy to see it and to hear from you. But the Q&A function is not for that purpose. If there are comments or feedback kind of generally left in the Q&A, those will be dismissed. Please, again, forward any questions, feedback, comments that you have to gic.info@mass.gov. And again, I will be monitoring that inbox today. We will only be answering questions from the Q&A function. While we are kind of going through the presentation, if you find that you have a couple of questions, please don't hesitate to take a look at the GIC's frequently asked questions page. We will be updating that after these sessions today to make sure that we've covered all of our bases there and make sure that we have all of the frequently asked questions available for you all there. So we'll be answering questions live throughout the session in writing, again, through that Q&A function. So please keep an eye on your questions there. Take a look at the questions that have already been answered before you ask yours, because yours might be answered already. So please definitely take a look. And we're excited to dive in. So I am going to ask Leslie, if you could jump to the next slide, please. Great. And the next slide. Okay. So we're just going to go over a few quick facts about the GIC. We always like to start with a quick look at our mission. And rather than read it off the slide, we'll just highlight some keywords. First, you'll see the word members. You're always at the heart of what we do. And as Matt likes to say, we serve those who serve, whether it's the Commonwealth or one of our 68 other municipal entities, local employers, et cetera, who are part of the GIC. The second thing I'd like to highlight is high quality and affordable benefits. The key here, and this will really be the theme throughout today's presentation, is we're really balancing two important objectives here. We are focused on providing comprehensive high quality benefits, but we also need to do so at a cost that both you and the Commonwealth can afford. As you all well know, the second challenge of affordability is getting more and more difficult, and we will touch on this a little bit more later, but wanted you all to know that these are the core pieces of our mission. Let's see. Okay, so moving on to the GIC goal slide. Great, thank you. Here are our goals directly, that kind of come directly from our mission. And rather than going through these, I want to just skip over them. You can read them here on the slide, just so that we can jump into really the meat of what we want to talk about today. Again, just a reminder of the benefits that we offer here at the GIC. Not going to read through them for you in the interest of time. This presentation will also be available for viewing after we present today. Some more key facts about the GIC, including how many members. This includes about over 100,000 retirees, which makes us the largest purchaser of health care in the Commonwealth, with about a $2.8 billion annual budget from our state appropriation. We're governed by a 17-member independent commission, and we partner with over 900 agencies in state, regional, and local government. Leslie, could you please jump to the next slide and the slide after? Great, and if you could jump one more. Great. Okay, so this slide I find really important for folks to orient themselves to how the GIC operates. So without getting too much into the weeds about how we're financed, it's a little bit different than what some of you may be used to. So the GIC is self-insured, which means that the GIC through the state budget holds the insurance risk and not the insurance company that you enroll with, or not your carrier. So when you receive your healthcare services, your doctor sends a bill to the insurance company that in turn, that company pays the doctor. The insurance companies then bill the GIC on a weekly basis, and we in turn reimburse the insurance companies for those claims. So an important implication is that if over the course of the year, members use more healthcare services than we expected, the state will pay more, but you, the member, does not. If members are using fewer healthcare services than expected, it's not the insurance companies that make money. It's the Commonwealth that ends up spending less than budgeted. So an illustrative example of this is many of you may have heard at the end of last fiscal year, the GIC requested a $240 million supplemental budget. This is exactly how the GIC is designed to function, so that when our claims run over what we have projected in any given year, it's the Commonwealth who holds the risk to pay that overage, essentially. In years where we run under what we have projected, that money reverts back to the Commonwealth's general fund. So last year was a year in which we ran over, and it was the Commonwealth's responsibility to pay that overage as is designed by our enabling statute. So I think that's a really important illustrative point to make, and just want to make sure folks are understanding that before we jump in any further. Here, I just want to highlight our questions and our process for asking questions and answering questions today before I turn it over to Cameron McBean for the next portion of our presentation. And Leslie, if you could just jump over to the question slide, the next slide, while we're turning it over to Cameron, that would be great. Cameron?
Thank you, Erica. I've been answering questions as well, so let me slide things around. We can move on to the next couple of slides, please. So we wanted to review the current benefit partners that we work with, the different insurance carriers that provide the GIC's benefit plans. For active employees or non-Medicare retirees who live outside of New England, our available plans are based on the subscribing members' geographic residence, so what state you live in. So outside of New England, we've got Access America. In Western Massachusetts, Health New England is still the provider. They are a subsidiary of Bay State Health's network. For broad network plans, we have the Harvard Pilgrim Explorer POS plan. We have the Mass General Brigham Complete HMO. And then we have Total Choice and Plus. Now, all of these plans are available throughout New England. And then we've got the limited network plans that are restricted network HMO style plans. And those are the Quality HMO and WellPoints Community Choice. Those are only available in the main part of Massachusetts, not the Caper Islands. Next slide, please. Then for our Medicare plans, we have three Medicare supplement plans, one each offered by WellPoint, Harvard Pilgrim, and Health New England. And then we have one Medicare Advantage plan, which is the Tufts Medicare Preferred. Next slide, please. Okay. When it comes to pharmacy benefits for active or non-Medicare participants, your pharmacy benefits are administered by CVS Caremark, and CVS SilverScript still administers the prescription benefits for our Medicare participants. For members on the GIC's active state employee plan, that's primarily management or non-union employees, we made the change last year to Altus Dental and Vision. Those contracts are still in effect. And then we do have one change that we are expecting, but we can't announce the final bidder or administrator until the impending commission vote we've got coming up on February 12th. This will be for the third-party administrator of our flexible spending accounts. Currently, that is Task. We do expect a new vendor to be our partner for the upcoming fiscal 27 plan year. Next slide. Now, Erica touched on this a little bit, but we do have one new vendor that we wanted to address here. The expense associated with GLP-1 weight loss medications is something that has been a driving factor in pushing the state into the current budget crisis. This slide outlines the issue. In the current budget, there was a proposal to eliminate coverage for GLP-1s for weight loss altogether, while maintaining coverage for other conditions such as diabetes. A bill authorizing such a mid-year plan change was not passed by the legislature, so we were able to maintain coverage. But the budget shortfall is still in place, which is why we were forced to look for a solution along the lines of Vida. The implementation of Vida is what has allowed us to maintain coverage for these GLP-1s at all for our members who need these medications for obesity. We can move on to the next slide, please. So the process we use to evaluate Vida as our vendor for this service was that we wanted to find someone that was a meaningful solution that offered a proven track record of working with members to achieve their goals with or without medication. So we looked at 4 vendors who all had experience working within CVS because we didn't have time to go through a standard procurement process. So we were looking for folks that we could work within the CVS ecosystem with. So what we were looking at was their service model, their strategy, their experience with similarly situated or sized clients, the financial impacts, what their services would cost, because this is money we are spending in an effort to save money, the impact on the members, and their organizational stability. Next slide, please. So after reviewing these 4 vendors, the GIC determined that Vida was the best option available for us based on their combination of member support, clinical and nutritional support, tools and resources for members, including monitoring equipment if need be, as well as evidence-based care focused on inclusivity and culturally sensitive approaches. So the impact of this is that Vida will be the sole prescriber, for GLP-1s for weight loss. There are some associated conditions such as sleep apnea that Vida will still have responsibility for. But if you are on a GLP-1 for diabetes, if you have a history of eating disorders, these are conditions that would disqualify you from continuing to work with Vida. That does not mean you cannot receive GLP-1s. That means that you would then continue to work with your regular provider care team rather than being obligated to continue to go through Vida. Next slide. Okay. There are a lot of questions. I don't know that we will try to be answering them within the chat. And with that, I believe we're turning things back over to our director, Matt Vino, to discuss, or is that Erica? I'm sorry.
Back to me. Thank you, Cameron.
Okay.
Thank you, Cameron. Thank you, Erica. Now we'll walk through first a little bit of context for the plan design changes for this year, and then walk through each of the changes that we have presented to our board for consideration. So on the next slide, we'll start with a little bit of context for the changes that we're proposing. Healthcare costs continue to rise sharply for everyone. This was true last year. It continues, unfortunately, to be true this year. And this, of course, includes the GIC. Based on our analysis, if we make no changes to GIC benefits, we are projecting a 10.9% average increase across all of our plans to our premiums for the coming fiscal year. So you'll see that here in the purple box in the middle of the slide. We continue to refine our projections, which is why you see ranges for that average increase in the blue boxes on either side. But a 10.9% increase for the GIC translates into about $170 million increase to the GIC's line item in the state budget. In October, the governor's budget office informed the commission that the budget cannot accommodate this level of an increase in state funding, and they requested that the GIC develop and consider a series of benefit changes to reduce our budget line item by about $100 million. So that is a substantial task for us, and the changes that are available to us are benefit changes through plan design. So that's what we bring to you today, and we bring it to you, as we always do, in advance of the vote by our commission on each of these plan design changes on February 12th. On to the next slide, please. So we understand that rising insurance premiums are a hardship for all of us, so we take this matter very seriously. We're doing everything we can on your behalf to keep this growing cost under control. But the challenges are very real, and they continue to increase for the GIC and for everyone else in the state, no matter where you get your insurance. When healthcare costs go up, the cost of premiums that you pay and that the state pays also goes up. This is driven largely by two dynamics, and those of you who have been in these sessions in the past, this will look familiar. Number one, the prices charged by doctors and hospitals for the services that they provide are rising at a faster rate this year even than last year. This is a problem that the entire state and policymakers need to face. And also the cost of prescription drugs, again, increasing faster than last year as the manufacturers of those drugs command higher and higher prices, especially for new drugs that they are developing and bringing to market. So to tackle these core drivers of rising costs, Governor Healy launched a healthcare affordability working group just recently, and has charged this group with developing real solutions to these long-standing challenges. As executive director of the GIC, I will be participating in this working group. I look forward to getting to work with my colleagues, and I can assure you we will be advocating for solutions that will preserve your health insurance benefits from future cuts to the maximum extent that we can. On to the next slide. So as you know very well, we pay for healthcare services, we and you do, in two ways. One is through health insurance premiums that both you and your employer share. Those percentages vary depending on whether you work for the state or a municipal entity, and out-of-pocket expenses, deductibles and co-payments, which you pay directly, often referred to as cost sharing. So the richness of a health insurance plan is generally described by how much of the total cost is covered by the insurance premium. And since the GIC has worked very hard to keep member cost sharing low and stable, our benefit levels are comparatively high. So you can see here that almost 92% of the cost of the services for our members are paid for by the premium, which are shared by your employer. It is important to note as we go through the rest of this presentation that even if all of the plan design changes that we're talking about are approved by the commission, this will generally still be the case. The vast majority of your cost, of the cost of your benefits, will be shared by you and your employer through the premium. And your plans will continue to be more comprehensive than many others that are available to folks in Massachusetts. On to the next slide. All right, so here we start to jump into the specifics of our proposals. This is the first change being considered to meet this budget objective that we've been given. But let me first orient you to the slide, since each of the slides that follow will have the same format. So below the blue bar on the left-hand column, you'll see the description of the proposed change. And as you read right to left, we include columns that display information about the impacts of these proposed changes. So first here, you'll see where it's applicable. We will have a comparison of the change to coverage that's in place in insurance plans offered by other public sector employers. The next column to the right, you'll see the number of members that are impacted by this proposed change. And then we have columns that show the savings to the budget that are produced by each change. So you'll see number one, the dollar change to the budget, and then the subsequent column, how much it will decrease our premium. And then finally, on the right hand, three columns, will show colored bubbles that are meant to note where each change aligns with our strategic priorities or does not align with our strategic priorities: member affordability, behavioral health access, and health equity. So here for this proposal, we lay out a premium contribution change that applies to the spouse of a state employee who retains insurance coverage after that employee has passed away. So today, those members pay 10% of the premium, while their deceased spouse may have a higher percentage. The proposal here is to have that percentage of premium remain at the level of the now deceased employee. So that would be either 10, 15, 20, or 25%. I would just note here that this is for state employee coverage only, does not apply to municipal coverage. As you can see, this change would impact a little over 8,000 members, will reduce our budget spend by $3 million, and certainly runs counter to our member affordability strategic priority because we are increasing the cost that is borne by these members. So that is change one. We'll move on to the next slide that lays out changes that are, for the most part, fairly small in terms of premium rate reduction and budget reduction, but are necessary nonetheless to meet our budget savings target. So the first row shows a proposed benefit change with a fairly modest impact. We're proposing to increase the copay that applies to visits to urgent care from $20 to $30. This would, as you can see through the benchmark, bring us in line with those plans that we compare ourselves to, would impact about 60,000 members who utilize those services, and would produce about $400,000 in budget savings to the GIC. Similarly, I'll skip over the second row for the moment. If you look in the third row, we are proposing to increase the copay for an ER visit from $100 today to $150. That will reduce our premium rate increase by about 1/10 of a point and impact about 41,000 members. Now, just to go back to that grayed out row, so whenever you see a grayed out row here, these are proposals that we have considered and rejected. So these are no longer really before the commission. So in that second row, we have in the past, through COVID, had mental health visits that are offered by telehealth with no copay, with no cost to the member. And we had expected to bring that to the commission for a vote, but we really want to keep this benefit because it supports our members' increased access to behavioral health services. And the last row here, the proposal is to scale back our coverage for hearing aids. There is a mandate in state law for a certain kind of coverage. We have tended to have more comprehensive coverage here, but we are scaling back some of that coverage to produce some savings. This will affect about 2,500 of our members and again, reduce our premium increase by about 1/10 of a point. So modest ones that we start here. On the next slide, rows 1 and 2 here are related. So at our December commission, we discussed increasing coinsurance that applies to our broad network plan. So if you're in a broad network plan, a POS plan, you have an out-of-network benefit, but you have traditionally had a 20% coinsurance when you access that out-of-network benefit. The proposal here is to increase that coinsurance from 20% of the cost to 40% of the cost. Again, this is in line with our benchmark comparators who have similar plans, but we have decided to modify this proposal slightly. We've decided to increase the coinsurance for medical and surgical procedures, but not apply that increase to behavioral health services. There's a shortage of behavioral health therapists, as many of you may know. Many of them do not contract with health plans, and our concern was very elevated that this would lead to a very substantial barrier to access to these services in those plans. The last row on this slide proposes a change to the way that our insurance plans pay providers who are out of network. This is really intended to provide an incentive to providers who are not in network with plans to become in network, and we would be reducing the amount that we pay those providers who remain out of network. Now, in this case, if you're in Massachusetts, this will apply only in Massachusetts because our members who are in Massachusetts are protected in state law from being balance billed by these providers for any remaining balance between what we pay them and what they charge. So you would be subject only to your cost sharing. So this is a needed reform for us and should, for the most part, for our Massachusetts members, not be super impactful. On the next slide, we are proposing increases to copayments for office visits to both primary care physicians and to specialists. This one, kind of bear with me, there's some detail to go through here. As you are likely aware, we have tiered copays for these providers in our current plans. Again, this is to incentivize our members to choose lower cost providers, which keeps our overall costs down. So the changes to copays is a little more complex. So there's a change for each tier. So for primary care providers, you'll see tier 1 copays would be increasing from $10 to $15, which is still well below the benchmark comparators and other plans. Similarly, tier copays would increase by $10 and tier 3 by $15. For specialists, the logic is similar here. We have 3 tiers. So tier 1 specialist copays would increase by $5 to meet the benchmark. Tier 2 would increase by $10 up to $70. And tier 3 would increase by $15 to a new level of $90. Finally, the bottom 2 rows here are, again, sort of linked. So we gray out the bottom row for a slightly different reason. The first row represents the alternative proposal that we are recommending to our commission. So here we propose to increase deductibles in our broad network plans from $500 from $500 to $750 for individual plans, and from $1,000 to $1,500 for family plans. Limited networks similarly would change from today a $400 individual deductible to $650, and for family plans from $800 to $13. So we've grayed out the lower increases in deductibles. That was the alternative, because a smaller increase here would just not be sufficient to meet our budget savings target. Finally, I think this is the last slide of our proposed plan design changes. We can go to the pharmacy slide. All right, so first here we are proposing the introduction of a new program called Prudent RX, which is a program offered through CVS, which manages our pharmacy benefit. This program lowers copays for members to $0 and saves the GIC almost $14 million. They accomplish this by applying coupons that are offered by the manufacturers of certain drugs behind the scenes, again, for high-cost specialty drugs. So these coupons reduce the member's copayment, as I said, and the rest of the value of the coupon accrues to the Group Insurance Commission and would be reducing our spending by approximately $14 million. So a material decrease. Members must enroll in this program if you are on drugs that are targeted by the program, or else your copayment will increase substantially. So there's nothing for you to do proactively, but if you are on one of the drugs that are going to be included in this program, you can expect to hear from CVS about next steps that you will need to take. Second and lastly here, we have proposed the elimination of coverage for GLP-1s for weight loss. As Cameron McBean noted earlier in the presentation, we have been doing our level best to maintain coverage for these drugs. I'm going to talk about that a little bit more in a couple of slides. We've engaged Vida to help maintain coverage, but save some money in this space. But the drug remains extremely expensive. So dropping coverage for these drugs would save the GIC approximately $46 million in the next fiscal year. So that concludes the proposed plan design changes that are before the commission. If we can go to the next slide, the GIC, sorry, bear with me. Okay. So the GIC, if we make no plan design changes this year, we were projecting a 10.9% increase, and we are still to this day. We continue to refine those numbers, which may change slightly, but that is where we expect to land through this process. So that's the red box in the upper right here. If the commission adopts all of the plan design changes that we've walked through today, that would reduce our state funding need by the $100 million that we've been directed by the governor's budget office to achieve. And that would decrease our premium by approximately 4.9%. Again, you see that here in the yellow box. This would produce a lower increase in our premium if we land where we expect to about 6%, which you see in the red box in the lower left. Just to be clear, premiums would still increase, but if these are adopted, would increase by a significantly smaller amount. It is important to note here that these are overall averages of all of our plan premiums. We have not set premium rates for each of our individual plans as yet. That will come at a meeting that we will hold later in February. So some plan premiums may increase by more than these numbers, and some will increase by less. So it's always important, as we say every year, to evaluate your plan options to make sure that they're meeting your needs. On the next slide, I think we just have a couple more slides here. As I noted earlier, we've worked really hard at the GIC to keep your copayments and your deductibles low and stable. In fact, aside from some minor adjustments that we made in fiscal year 24, we have not increased member cost sharing in 8 years. This is very unusual in the insurance market. Employers in the private sector routinely increase member cost sharing to keep their premiums low. We have done everything that we can to resist that, but with the state's budget challenge, that is apparently no longer feasible. And as a result, we must propose some modest cost sharing increases here, as well as premium contributions for surviving spouses. In addition to that, we're making some needed reforms to out-of-network payments, implementing a new pharmacy savings program, each of which should have minimal impact on our members. And GLP-1s to treat obesity is just a unique challenge. So I wanted to speak a little bit more about that on the next slide before I wrap up. So the astronomical cost of these drugs to treat obesity is a very significant driver of our rising costs. It was last year and it is this year. And it is for all employers who provide benefits, who provide this specific benefit to employees. Most insurance companies and many, but not all employers are dropping coverage for these drugs. So this would be a difficult choice for our commission because, as you see in the second bullet here, these are very effective drugs and they bring a great deal of health benefit to our members who use them. We have also, as Cameron noted earlier, we've just recently launched the Vida Health program to try to manage this cost. So this is a very fluid area for the GIC. We're trying our best to maintain coverage, but in order to meet the budget target that we've been given, we have to put this before our commission for their review. And as you can see, that and all these changes will be before the commission at their February 12th meeting. So on the next slide, I'll close out this section, and I think we can move pretty quickly into questions and answers. I wanted to give a brief overview of the process that we go through to prepare our rates and plan design. The first step is to bring to the commission in December what we think our aggregate average increase will be, which I noted earlier is 10.9%, and that is sort of status quo with no plan changes. And so the second step, which we did last week, was to recommend any plan design changes that may need to be implemented for the coming year. As I noted in the last slide, we decided not to make changes in a few areas, but we do have a number that we've put forward. We then come back to our members as we are today through this and throughout this week to inform you of the outcome of this work to date. But it really comes down to the commission's vote on plan design on the 12th of February, and then again on the 29th. Actually, I think it's the 26th of February. So we have here 26th of February to vote on specific rates for each of our plans. This will all be brought to you as it is every year in our benefit guides, and will be reflected in what you will see in the My GIC link portal for annual enrollment. So with that, I will conclude this section and hand it back. I guess just a reminder, if you're submitting questions, you can do that anytime in the Q&A. I'm sure staff are actively answering those questions. If you have something more to say that is not a question, but want us to hear your voice, we would love to hear that through the gic.info@mass.gov website. Also, if you have specific, very specific circumstances that we can help you with, we'd love to do that online also through that email address or through our online form. With that, happy to turn it over. I think we go to questions.
Great. Thanks, Matt. Not to questions yet, although we have plenty in there and quite a bit about Vida. So folks who are asking questions about Vida, hang tight. We will get to those questions. But right now, I want to turn it over to Paul Murphy, who's going to go through enrolling in and updating your GIC benefits, as well as letting us know about annual enrollment coming up soon. So, Paul?
Thanks, Erica. For the next couple of slides, I just want to highlight some key dates coming up, and if you can go to the next slide. So this year's annual enrollment is going to take place April 1st through May 1st. Members can enroll in GIC benefits, make coverage changes, individual family, family to individual. They can cancel their coverage and they can enroll in the buyout program, or they can also change their health plan. A quick reminder, this year's benefit guides will be available right before the start of annual enrollment on April 1st. The guides will be online on GIC's website, as well as the GIC member benefit portal. Go to the next slide. So this slide is just a reminder that the GIC does have a member portal. We launched this 3 or 4 years ago. We currently have about 136,000 members using our portal to update, submit changes, view their benefits 24/7, change dependent information, and enroll throughout the year with qualifying events. So reminding everyone, if you want to take advantage of our member portal, you can visit information on our website at mass.gov/GIC. And you can also register for the portal for the upcoming annual enrollment so that you can view your benefits directly online. Next slide. This slide is just a reminder about our health plans, phone numbers, and their websites. Many times GIC gets a lot of questions. You'll see at the top of the slide, finding a provider, accessing tiered doctors, determining which programs are available, understanding your coverage, and one popular request we get all the time, if you need an ID card or a replacement ID card. All of these questions, you must go to the health plan directly, either call them directly or visit their website. If you want, you can also go to the GIC's website, where we have information about all of our vendors. And within that section of our website, there are hyperlinks that'll take you directly to the GIC microsites for each of the health plans. And I think that's the last one, Erica?
It is the last one.
Okay.
Okay. So now we're going to turn to questions here. First, what I wanted to do since we have a lot of questions about Vida. Leslie, if you wouldn't mind going back to the slide about Vida. Let's see, for your sake, if we want to go back to slide 15, that would be great while we're here. Okay. So we have quite a few questions about Vida that have come up, understandable, and want to just talk through some of this with you all. So first, we've gotten a few questions about who is Vida for? So Vida is a platform that is available to all GIC members. You will see that you likely got a letter from Vida. So that is a platform that is available to all GIC members. But mostly, I think what you're all concerned about is for those of you who are already on a GLP-1, what for weight loss or for the treatment of obesity specifically, what does that mean for you? So if you are using a GLP-1 for a diagnosis other than for weight loss, specifically for diabetes, Vida is only required if you are using a GLP-1 for the treatment of obesity. So if you have diabetes, you will be kind of excluded essentially from Vida. So it is only for that purpose. Want to acknowledge here that we understand that folks are feeling upset about the fact that this is really targeted at GLP-1s for the treatment of obesity. We understand that and we share those concerns. At the same time, we do have a responsibility to the Commonwealth's budget to try to rein in those costs where we can. And so, as Cameron and as Matt have explained, when we were faced with eliminating GLP-1s or doing what we could to maintain coverage of GLP-1s for the treatment of obesity, we chose the program that would allow us to maintain coverage for GLP-1s for the treatment of obesity. We know it's not the ideal because of how folks were accessing them before. So we want you to know that we understand that. We're sensitive to that. And our goal was to make sure that we were able to maintain coverage, which is what we were able to do. To be clear, on the 12th, the commission will have a vote in front of them to eliminate coverage for GLP-1s for the treatment of obesity completely. That is something that is still very much on the table. And that is, again, will be before the commission on the 12th. So I just wanted to kind of make those points here. We understand that there is a bit of frustration between members and the GIC, particularly where folks have already been working with a provider. We understand that, and Vida was the selection that we went with because of their ability to kind of work and keep providers informed. So I'm going to go ahead and start going through the questions that we have, many of them related to Vida. One of them, I'll start off by kicking it over to our general counsel, Andrew Stern. We've gotten a couple of questions generally about our privacy protections, HIPAA, through the utilization of Vida. And Andrew, if you wouldn't mind just speaking a little bit to that, that would be really helpful.
Sure. Vida is HIPAA compliant. Its website is high-tech certified, or certified, which is a HIPAA certification. They are under the BAA, which is a business associate agreement, another HIPAA required sort of contract that protects our members, that flows through CVS. I know that people have reached out and felt that there are places where they interact with the Vida platform that suggest Vida might be monetizing their information. I had a meeting with their general counsel last week. They assured us that is not correct. I am waiting for them to follow up with us and provide public information to our members to confirm that position. but anything that involves your health information is private and is protected under HIPAA, just as if you went through any other telehealth platform or to your doctor directly. Is that enough? Erica, did I cover everything you wanted?
Yes, I think you did.
All right.
Thank you. Let's see here. Jumping back to some of our other questions. Hold on just a moment, please. So another question that we've gotten about Vida is, we implemented on January 1, became live for us at the GIC on January 1. And so when do you have to switch over to get your prescription for a GLP-1 through Vida? So we do have a 90-day grace period that began on January 1st. You need to go through the process with Vida by March 31st in order to continue to get your prescriptions and to continue to be on your path. So please go ahead, enroll if you are already on a GLP-1 and want to maintain that for treatment of obesity. Please go ahead and visit the Vida website. Emily, if you could, or Leslie, if you could pop that enrollment website into the chat for folks, that would be really helpful. So please go ahead and do your enrollment through Vida by March 31st in order to be within that grace period. I would advise, given that it can take a couple of weeks, to not wait until March 31st, but to please get it done as soon as you're able. Okay. Let's see here. So we did have a question about how is Vida saving money? That's a great question. And we're not trying to hide the ball here. Vida will save the Commonwealth and the GIC money, frankly, with members who have decided to discontinue their use of GLP-1s, whether there are too many hoops to jump through with Vida or it's no longer for them. That is where the cost savings will come from. No need to, like I said, hide the ball here. Just to be completely transparent, that's how that will work. Let's see. Sorry, I'm doing a lot of things here to try to get all these questions answered. While I am digging out some of the remaining Vida questions, if we could touch on the ask that we get every year about why the GIC does not offer a +1. That would a +1 plan. That would be really helpful. Matt, if you wanted to jump in on that first and kick it over to whomever you'd like.
Sure. Thank you. I know there's the comment, or at least one comment that I saw, there's some frustration that we continue to have a message here that we've had for many years now, which is that we have evaluated that option and have decided not to proceed. That is, in fact, the way we are continuing to proceed. We do evaluate it every year. One of the things that we have to be very mindful of is that does not change the amount of money that we spend as a plan sponsor every year. It simply reallocates costs between certain subgroups of our members. And so the implementation of a +1 plan type would have a significant impact on those who would remain of necessity in the family plan. So we are trying to balance a variety of different impacts here across our entire membership.
Thanks, Matt. Let's see here. We're also getting a lot of questions about Prudent RX and what types of drugs are included and how members would receive that information. I'd like to turn that, my first thought is to turn that to Cameron, but Matt, please go ahead and your prerogative.
No, I'll kick it to Cameron, it's fine.
Great.
Sure thing. Yeah, the Prudent RX program, excuse me, it is what's known as a copay assistance program. This is offered by CVS. It is a way, we've all seen commercials on TV for a drug that's being marketed that says if you can't afford your prescription, coupon maximizer, sorry, thank you. Right to AbbVie or Eli Lilly or whomever, and we can help you. And what these drug manufacturers do is for plans that have higher copays than the GICs, where our top prescription drug copay is $65 a month. There are some where sometimes it may be a coinsurance percentage. Sorry. So these manufacturers will offer coupons to participants. And, what that's intended to do is assist people who don't have relatively low copays, such as the GIC offers on our prescription plans. It offers them money to offset those costs. So what Prudent RX does is it captures those dollars directly from the drug manufacturers, thereby lowering the plan's overall spend on these drugs. You would still pay the exact same copay that you already are responsible for. So it is a net wash for participants. You would still pay the same copay for whatever qualifying medication.
Cameron,
Usually these are
Cameron,
specialty. Yes.
that's incorrect.
Oh, I'm sorry.
The drugs that are on the Prudent RX plan, once a member enrolls, they pay nothing for those drugs.
Okay. Thank you. I'm explaining the wrong program. Yeah. Andrew, do you want to take over since I just led us down an incorrect path? My apologies.
Sure. It's a coupon maximizer program. It will be some subset of specialty medications that are extremely expensive. We don't know what the list of those medications are because they change over time. And since we haven't adopted the program, we don't have the information at the moment. Once a member enrolls in the program, they pay nothing for the medication. And the state will get the benefit of the full coupon available for that program from the manufacturer. There'll be extensive outreach from CVS if we adopt the program to members who have scripts for whatever the drugs are that would fall within the program. And we'd have a lot more information at that time.
Thank you, Andrew.
Thanks, Andrew. Let's see here. We've got so many questions coming through. We're doing our best to keep up. So let's see. We do have a question about when our benefit decision guides will be made available for you all to view. Those will be made available immediately before annual enrollment begins on April 1st with our most up-to-date information for the upcoming plan year. Let's see here. So we have a question here about how much money we are anticipating saving with the implementation of Vida. Matt, if you wanted to start that one off.
I'm sorry, Erica, can you repeat the question? I was responding to one in writing.
Sure. We're all doing multitasking today, trying to get questions answered. We had some questions about how much Vida is projected to save the GIC.
So when we presented this to the commission, my recollection was that we projected a $15 million savings to the GIC.
Thank you.
And we implemented a separate unrelated program that would create about $5 million in savings. So we were attempting to get close to the amount of our budget funding that was vetoed that specifically was targeted at GLP-1s.
Okay, thank you. Great. Okay, let's see here. Trying to get to all the questions. Sorry, scrolling through here, trying to find all the questions. 1 second. We had a couple of clarifying questions. So one was for these potential changes coming up, are these for actives and retirees? Are they for non-Medicare, Medicare plans? Matt, if you could just speak to kind of the group that these potential changes pertain to.
Yes, that's a really good point. So the changes that we've presented are largely focused on our employer-sponsored plans, our active employee plans. All of the changes to copays and deductibles relate only to the active employee plans. Andrew, can you help me with those that would apply more broadly to all of our members? I believe GLP-1 coverage would be in that category as well.
I apologize. I was answering a question. I didn't hear what the beginning of your inquiry was.
So the question was, to what degree any of these plan design changes apply to Medicare plans or our active employee plans? And what I noted is that the changes to copays and deductibles and GLP-1s, the changes to copays and deductibles apply only to our active plans.
That's correct.
And of the others?
Well, currently GLP-1s are not covered on our Medicare
Right.
plan. So that one doesn't apply. And the Prudent RX would apply on the active side. It's not on the Medicare side if it went on that program. I'm not sure what other benefits you might be wondering about.
This is an area where we can follow up with some detailed information in our FAQs. Thank you for the question.
Thanks, Matt. Just getting a couple other questions here. So we've had a few folks ask if these meetings will be recorded and made available. Yes, they will all be recorded and made available on our YouTube page. So this session this afternoon, this evening session at 6, as well as Thursday's session at 9, they will all be recorded and made available, as will the presentation slide deck. And then we've had other folks asking questions about the vote that's happening on the 12th. How will you know what the outcome has been? Are they public? Yes. So the meetings themselves are public. You can view them, again, live streaming on YouTube, and we can make those links available to you. Please check our website. We're also available on X and on LinkedIn for you to be able to find our GIC YouTube page. Emily or Leslie, if you have a quick link to the GIC YouTube page, if you could drop that into the chat, that would be very helpful. But the votes will be public on February 12th, and you'll know the outcome of them immediately following that meeting. The vote again on February 12th is on the potential plan design changes that we've gone through today. There will be another vote on February 26th, which is going to be about voting on the actual rates themselves. So 2 votes coming up, one in February 12th and one on the 26th. Let's see here. You don't need to attend all of the public information sessions, just a heads up. They all will have the same content, but they will all be available for you to view. Just like you don't need to be present for the vote meeting, but you can certainly tune in and watch. And many of you have also asked how you can share your feedback with commissioners ahead of this vote, we would encourage you to use gic.info@mass.gov. Yes, there is an auto reply message that you'll get immediately. That is just a standard auto reply, but I personally monitor that inbox. So yes, they will be reviewed and that feedback will be shared with our commissioners. So if you get that auto reply, know that is part of the normal course. And I have access to that inbox and will be reviewing it. Okay, let's see. Now that we have kind of our bearings, hold just a moment, please. So we have a question about whether there will be in-person insurance fairs during the annual enrollment period. No, we will not have in-person. We will continue to host virtual health fairs where we post all of the videos provided by our carriers on our website so that you can review and learn more about those carriers. So we will post those as we get closer to annual enrollment, but we will have those available. Let's see here. Okay, if you have specific questions about your personal situation, your interaction with Vida or anything like that, please go ahead and reach out to us directly. We cannot answer personal questions in the Q&A function. So just wanted to give a reminder for that. Let's see. Having a clarifying question here. If it is voted that GLP-1s will not be covered, then will we not be using Vida? So let me just clear this up here. Vida has been implemented as of January 1st. If you are utilizing a GLP-1 for the treatment of obesity, then you must go through Vida to continue getting that prescription. We are currently in a 90-day grace period so that you are given the time to enroll with Vida, should you find that that's the path you want to go down. If you have a diagnosis or you're being prescribed GLP-1s for diabetes, Vida is not something that you need to enroll in. For the vote on the 12th, the vote on the 12th is not about Vida. The vote on the 12th will be about whether or not coverage for GLP-1s for the treatment of obesity is maintained. So on the 12th, commissioners will have before them whether or not to eliminate coverage for GLP-1s for the treatment of obesity. That is a separate concept from Vida. If they vote to eliminate coverage for GLP-1s for the treatment of obesity, then yes, the Vida portion would also go away because if you're eliminating coverage for that, then you wouldn't have that through Vida either. So I hope that helps to clear up that question. Let's see. Okay. So we've had a couple of questions specifically about the hearing aid portion of the potential plan design changes. So Matt, if you could speak to that a little bit more in detail about what that potential plan design changes.
I'm sorry, can you say that again, Erica?
About the hearing aids, that portion of the plan design, if you could just clarify what would happen there if that was something that the commission took up.
Yeah, if we can go back to that slide, it's got the details on the slide. I may let's see which slide it is. Yeah, so it's, as you can see here in the lower left, in order to reduce the benefit but maintain compliance with the state law, we're reducing the coverage for those who are under the age of 21, from every 24 months to every 36 months. And we're removing coverage for the 22 plus age group.
Thanks, Matt. Okay, let's see. Oh, please, just scrolling through these questions.
Yep. While you do that, I did want to note that for those of you who are in a union, just want to note that on the dental and vision coverage, you may be receiving information from your union's health and welfare benefits area. So just to make sure that you're understanding that the GIC offers this benefit, but organized labor in some cases also offers this benefit.
Thank you. Andrew, we're still getting a couple of questions in about how folks will know what prescriptions are included in Prudent RX, noting that there isn't anything listed on the website. Is that something you could speak to?
If the commission votes to implement the prudent.
Andrew,
Fine.
your audio is cutting out a bit.
Let me switch it.
Sure.
There'll be a lead-in time to the Prudent RX program if it's decided that we will be moving forward with that program, we will be getting the list. We can post it on our website. There'll also be extensive outreach to all members who may have a script because CVS will know of a medication that falls within the Prudent RX program, because they would need to enroll to be covered under the program. Otherwise, and this is the downside to the program, is if you do not enroll in the program, you do not have coverage for that drug, and you'll be paying the full cost. So we don't want that to happen. There would be an implementation outreach program, and people who have scripts that will be affected at that time will get more than one communication about that and outreach personally to enroll. If you get a script subsequently for a drug that will be in there, there'll be direct outreach right at the time. I wish I had more information, but at the moment I don't.
Thanks, Andrew. Okay, we have a couple other questions here with our remaining time. So let's see. Could someone please verify whether out-of-network coinsurance is currently at 20%? Could you also verify whether this increase to 40% will apply to all kinds of care? Please note the exceptions if there are any.
The exception we've noted in the presentation that the questioner may have missed is that it applies to all non-behavioral health services, because we have just given the unique dynamics around behavioral health services, we were concerned that raising that coinsurance would lead to a pretty substantial access issue for those services.
Great, thank you. I think folks are still wanting to hear a little bit more about the +1 plan. I know that we've talked about that at length, and we talk about it every year. Matt, if you could just reiterate what it was that we have discussed over the +1 plan, that would be helpful.
Yeah, I don't know if there's a whole lot more for me to say. I'll just reiterate that we do continue to evaluate it. We have to, changing that plan type or introducing a +1 plan type is simply about shifting costs between different subgroups of our membership. So doing so may provide some benefit to one subgroup of our membership, but would increase the premiums for those who would remain on the family plan. So we're trying to maintain some stability across our entire membership by maintaining our current plan type structure.
Thanks, Matt. Okay, let's see here. Just noting that we have 5 minutes left here, and so we're going to try to get to as many questions as we can with the remaining 5 minutes. If we haven't gotten to your question, please know that we will have a report of every single one of these questions that has been asked, and we will compare those with our existing FAQs and add to our FAQs where it's warranted. So please don't worry if we haven't gotten to your question. We will make sure that it's been addressed, even if it's after this session. Okay, let's see here. So a question, if the commission votes to eliminate GLP-1 coverage for the treatment of obesity on February 12th, when would the loss of coverage take effect? That would be along in parallel with the plan year. So it would be July 1 of 2026. So it would be this year. Okay. Let's see here. So we have a question, a retirement question, which is usually what we get most of our questions on. Do retirees with, and it's related to GLP-1. So do retirees with Medicare B and Medicare Advantage, also register with Vida for GLP-1s for treatment of obesity? It seems like GIC coverage for retirees, including hearing aids, are being reduced more and more. So I'm not sure if Matt or Paul, this would be an appropriate question for you, but I'll start with Matt.
Yeah, kick that one to Paul.
Okay. I think what Andrew was saying, that the GLP-1 doesn't apply to Medicare population.
Andrew?
Yeah, Medicare does not cover GLP-1s. And so it wasn't being covered. If that changes and Medicare covers it, it will be done through Medicare. It will not be part of the Vida program.
Great, thank you.
And Erica, if I just want to clarify, I know we got a couple minutes. There seems to be a few questions coming in about the hearing aid benefit for the 22 plus. It says coverage elimination. I just want to clarify, it only applies to the hearing aid benefit. We are not eliminating dependent coverage. Dependents will continue to be covered until the age 26. I just want to clarify. There seems to be a few questions on that one too.
Thanks, Paul. I got a good question about whether our partnership with CVS as our PBM means that our benefits only apply at CVS or that they apply differently at other pharmacies. Just wanted to pose that question live. Matt, if you wanted to take the first stab at that or pass it on.
I'll pass that on.
Cameron?
I'm sorry, I was also typing. What was the question?
Does the CVS partnership or our partnership with CVS as our PBM, does that mean that our benefits only apply at CVS pharmacies or that they apply differently at other pharmacies?
No, you can utilize other pharmacies for regular retail fills. Where it can get a little more complicated is if you are on maintenance medication. So if you say, for example, take atorvastatin for high cholesterol or a blood pressure medication. So it's something you're regularly taking day after day, year after year. CVS requires that the members use their mail order service for 90-day prescription fills. You can get an exemption from that requirement, but it does require outreach and annual recertification or reapplication with CVS each year.
Thank you, Cameron. Oh, I see we're at 1:30. I have one more clarifying question. Under this proposal, or these potential plan design changes, would we lose 3 free mental health visits or not? Matt, I can answer this one, but I'll kick it to you.
Yeah, no, go right ahead.
No, so no. That is a box that has been grayed out. That's been removed from consideration for the commission. Okay, so thank you to all of you who have joined us and who have bared with us while we try to multitask, answer all of your questions as best we can in writing. I see at this moment we have answered 233 questions in writing, and we have still 115 open. So we will be taking these questions back and comparing them to our FAQs to see if we need to update our FAQs in any way. So please stay tuned for that. We thank you again for joining us. Please stay tuned for the recordings if you'd like to catch up and take a look once these have all been posted to our YouTube page. Again, if you have feedback for us, for our commissioners, please go ahead and email us at gic.info@mass.gov. Again, I monitor that inbox, so there is a real person who looks at it, and we'll be sure to share your feedback with commissioners. Thank you again for all of you attending, and we appreciate your feedback.
Thank you all.